Welcome to Sleep Medicine Disruptors, a medical dental collaboration. It's time to invite dentistry to the table. Our team leader, Dr. John Bouzis, is a practice limited to sleep medicine, providing both oral appliance therapy and PAP by physician prescription only. Dr. Jay Corsandi also always works under the prescription of a physician and has treated over 5,000 sleep patients in the last 5 years with both PAP and oral appliance therapy. Dr. Mohammed Amar Hussaino is a pulmonary disease specialist boarded in sleep medicine, and myself, Dr. John Viviano, has a clinic in Ontario, Canada that provides conservative therapy for sleep disordered breathing by way of oral appliance therapy. I'd like to start off the presentation by presenting excerpts from the Sleep Innovation podcast where Dr. Seema Khoshla interviewed Dr. Azizi Sexas.
We are going to take care of the people that we serve. It's one of the most sacrosanct virtues and values of being in this field. We want to start to build a coalition and a community of people to do this type of work.
Well, let's take a look at the current status of sleep disordered breathing. Approximately 90% of the adult population remains undiagnosed, and children are mostly ignored. 90% of those adult patients that are diagnosed are prescribed positive airway pressure, of which 50% remain compliant at 6 months and 17% remain compliant at 5 years. Dr. Khoshla expressed some serious concern.
So help me with this. I feel like we are all overworked and that we are perpetually in survival mode.
And Dr. Sexas shared his vision as to the solution.
We got to reimagine healthcare in terms of education, in terms of clinical care, in terms of research, in terms of venture, meaning our relationship with the private sector. And lastly, we need to reimagine how healthcare provides outreach and service to the community. In order for us to do this, we need an entire arm.
What about dentistry? 80% of Americans have dental benefits, and 79% of Americans visit a dentist every 2 to 3 years. In Canada, 80% of Canadians have a dentist, and 86% visit their dentist every 2 years. Patients are accustomed to attending for regular dental follow-up visits. Dentistry provides direct professional access to patients with the ability to screen, offer therapy, and follow-up resources. Active screening of each patient of record would reduce undiagnosed levels dramatically, helping to set the patient on their path to wellness, whether it be through behavioral modification, positive airway pressure, or oral appliance therapy.
When we see that there aren't enough sleep clinics out there to serve the great need that we have in the community, we need to turn everything on its head and to say, how do we reach these individuals? Develop new solutions, not just technology solutions, but solutions of care and workflow so that we can better reach people. And that is the key.
New solutions of care and workflow. So we have to think differently than we have been thinking over the last 30 or 40 years. AADSM, respected evidence-based organization. Oral appliance therapy, respected high success rate conservative therapy. An MD-DDS collaboration provides PAP non-adherent patients easy access to oral appliance therapy with similar health outcomes to positive airway pressure. There are many benefits of an MD-DDS collaboration. They include mobilizing the entire dental workforce, which can provide screening, referral, oral appliance therapy when appropriate by physician prescription, and follow-up. But is dentistry and oral appliance therapy worthy? Well, clearly a single treatment offering is not working and has led to polarized clinicians. But does the evidence support oral appliance therapy? Well, let's quickly review the evidence. PAP is better at reducing AHI, but compliance favors oral appliance therapy. Both objective health outcomes and functional health outcomes are similar. Blood pressure outcomes, cardiovascular mortality outcomes, also similar. So how does one explain this? A dose-response relationship is observed between the hours of CPAP use and the range of subjective and objective health outcomes. Oral appliances are preferred to PAP over many studies that reviewed this issue. This may in fact be the reason that oral appliances enjoy better long-term adherence and more hours of nightly usage. So oral appliance therapy is less effective than PAP in eliminating apnea, but higher long-term compliance and higher hours per night use result in similar health outcomes.
In order for us to do this, we need an entire arm.
AADSM provides evidence-based clinical guidance and educational requirements ensuring competency. We propose that a collaborative effort with the AADSM can provide the AASM the army they need. Next, Dr. John Bouzis will review the MD-DDS collaboration model, including information about an existing working model from Alberta, Canada. Following this presentation, your next question should be, why is dentistry not already at the table?
OSA is definitely a medical problem, although some would like for you to think otherwise. It is a medical problem, sometimes needing a dental solution. We're going to make a consideration regarding testing guidelines. We're going to take a look at the Alberta model, where in 2016 they had their rough draft, with the final version adopted in 2019. And we're going to look at some of those highlights. They determined who needs to be tested and how, and who performs the follow-up. They describe methods of an initial screening, if indicated, how to do a comprehensive assessment in order to make a determination whether an in or out of lab study was indicated, to be interpreted by a board-certified sleep physician, and after which treatment determination could be made. Care and follow-up and monitoring should be a shared collaborative responsibility. These standard of care guidelines were designed by both representative organizations. I think this could be a great starting point from which to build a program here in the States, even though we have vastly different healthcare models. First, we want to create healthy airways. We do so by dentist screening children. If there's no problems, we monitor growth and development on recalls. If problems are identified, then we manage growth and development, while also creating a healthy adult airway. We use protocols like Healthy Start, orthodontics if indicated, and then we continue to monitor the patient on recare visits. Adults, on the other hand, are a different situation. We don't create a healthy airway, we maintain an airway. This first model here is describing a situation where diagnostic testing is allowed. We screen the adult population. If they're not at risk, we follow them on recall. If they're PAP compliant, we review the compliance reports and consider overnight oximetry in order to take a look at the SpO2 values. If they're PAP non-compliant, we'll visit that in a moment. If they're at risk, yet undiagnosed, then we order or dispense a multiple night HST with an MD interpretation. Regardless of whether the AHI is less than 30 or over 30, we consider SpO2 values, heart rate variability, and the comorbidities. We perform a consultation discussing OSA and all options, especially PAP. At this same visit, we evaluate the patient's candidacy for an oral appliance. We gather all clinical notes and study results, and we provide that to the physician for collaborative care. The first line of treatment generally is going to be PAP, and the physician will create a letter of medical necessity and a prescription for that and send it to the DME. Alternatively, a decision may be made by the physician for an oral appliance, after which they will provide us a letter of medical necessity and a prescription for a mandibular advancement device. If the patient is placed on PAP, we monitor the compliance reports and the overnight oximetry as previously described. If the patient fails PAP, then we ask for medical collaboration. That could be for a referral for a hypoglossal nerve implant, for an ENT evaluation, or an alternative to CPAP, an oral appliance. If it's an oral appliance, we deliver a custom fabricated appliance, titrate to efficacy, and then administer an HST. Then we refer the patient back to the medical provider for collaborative care. These two processes need to be better monitored. First, the patient that is PAP compliant. We need to continually check that on recalls because simply because they're compliant today does not mean that they will remain in compliance. And then the patient that is non-compliant, we need to refer them back to the physician to get them back in the loop. Always, before a dentist orders an oral appliance, a physician letter of medical necessity and a prescription should first be obtained and in records. Now we're going to discuss a situation where no diagnostic testing is allowed. We identify the patient, and if there's a need there, we do a 3-night self-reporting HST that takes care of their variability of sleep, something like the night owl. Regardless of whether the AHI is greater or less than 30, we consider SpO2 values, heart rate variability, and the comorbidities, and we refer that patient back to the medical team for a definitive testing, whether they want an HST or a polysomnogram order. But now there's 3 processes that need to be better monitored. First, the PAP compliant patient. We need to make sure that they remain compliant and check that on recalls. And the non-compliant patient, they need to be referred back to the physicians. And if we do make an oral appliance, we need to make sure that we return that patient to the physician for evaluation of efficacy. Always, before a dentist orders an oral appliance, a physician letter of medical necessity and a prescription should first be obtained and in records. If there's going to be a significant delay in obtaining a diagnosis or getting treatment, as determined and ordered by a medical provider, a protective temporary appliance could be fabricated for safety. MyTap is an example of that. It's optional based on need, physician referral, and patient risk. The need for the delivery of an oral appliance should be made by balancing the severity of the patient's circumstances, the comorbidities, and any expected delay in obtaining a diagnosis and initiating treatment as determined by a physician. If there's a delay in treatment or a perceived risk, we deliver a MyTap. We titrate it to subjective symptoms. We can test it with a night owl, pulse oximetry, or a like device to efficacy. But regardless of whether the patient is a responder or a non-responder, we send that patient back to their physician for collaborative care. So, is it CPAP or an oral appliance? I think it's both. We subscribe to OSA being a medical problem, sometimes needing a medical solution, sometimes needing a dental solution, and sometimes both, but always needing a collaborative effort between professions, with both having a seat at the table. The Agency for Healthcare and Research and Quality, the U.S. Department of Health and Human Services, reported studies failed to show long-term benefits for CPAP. The studies were highly inconsistent in how they defined breathing measures, such as AHI and ODI, and by extension, how they define OSA, even though they followed standard PSG criteria. No significant effects were found as a result of CPAP on long-term clinical outcomes for adult OSA patients. At some point, we may all be asking for a seat at the table. And by that, we mean a seat at the table in collaborative care.
I'd like to thank you for taking the time to consider our medical-dental collaboration, and we'd like to send a shout out to all the other hardworking participants.